members for joining us at today's briefing. Right now, across the country, citizens are coming together to protest racial injustices. These protests began in response to the public lynching of George Floyd by Minneapolis police officers and the recent killings of several other African Americans at the hands of those who took an oath to protect them. My prayers go out to the Floyd family and the other families of a long list of other victims and their loved ones. I stand in solidarity with all those who are peacefully protesting and patriotically challenging the status quo. But these protests are about more than the treatment of African Americans at the hands of police. They're also about the systemic racial inequities that have festered in our society for years and are now magnified by the coronavirus that we're here to talk about. This racial inequity is particularly stark in healthcare and has been laid bare by this pandemic. African Americans, Latinos, Native Americans, and other people of color are testing positive, being hospitalized, and dying from COVID-19 at alarming rates. Nationally, African Americans are dying at a rate that is double what would be expected given their share of the population. Latinos have been infected at a disproportionate rate in nearly every state that report these data. And Native Americans, who represent just 4% of the population in Arizona, are 21% of the coronavirus deaths in that state. At last week's subcommittee briefing, we heard from mayors like Keisha Lance Bottoms of Atlanta, who warned that the racial inequities exacerbated by this crisis, and I quote here, deserve an urgent and larger national conversation, end of quote. The high rates of coronavirus infections and deaths among minorities and the consequence of underlying disparities. People of color are more likely to work in essential jobs where they are at greater risk of contracting the virus. Minorities are also more likely to suffer from the lack of diagnoses and treatment of chronic health conditions such as diabetes, heart and lung disease, which increase the risk of death from coronavirus. Black and brown communities also tend to have inadequate healthcare facilities and more crowded housing conditions. The federal government needs to address these disparities now. We need to ensure communities of color that they will have equitable access to coronavirus testing, including mobile testing, as well as high-quality health care to address these chronic health conditions. We need to make sure essential workers have the protective equipment that they need and receive decent pay and paid leave so they are not forced to work when they are sick. We need to make sure the nation's immigrant communities can get life-saving treatment without being targeted by immigration officials. And we need to ensure minority communities have the federal investment they need to thrive, both during this pandemic and after. To successfully address these racial disparities, We also need good data. In April, Congress passed a law requiring the administration to provide racial data on coronavirus infections, hospitalizations, and deaths. Unfortunately, the first report did not provide the comprehensive data we need. The goal of today's briefing is to examine racial health disparities in the coronavirus pandemic and explore how we can ensure an equitable response. Today's witnesses are uniquely qualified to do this. We will hear from public health experts, physicians who have treated coronavirus patients in minority communities, and community activists who have seen firsthand how this virus has deepened existing inequities. I am hopeful that this committee will approach these issues thoughtfully and respectfully and search for bipartisan solutions. I now wish to recognize Ranking Member Scalise for his opening remarks.
Thank you, Mr. Chairman. As we start this hearing, our country is facing two very different crises. We're facing the shutdown of our country and our economy with COVID-19 and the pandemic that spread throughout the world. And we're also dealing with the anger stemming from the senseless murder of George Floyd, as well as the protests that followed, and also the violent rioting and burning down of some of our cities. Mr. Chairman, my prayers are with George Floyd and his family. My prayers are also with retired police captain David Dorn, who was senselessly murdered trying to stop a looter, as well as the other law enforcement officers and people that were just trying to protect their communities from the senseless violence that's spurred out of this. Clearly, as we confront all of these challenges, this committee should be focused on following the facts and working on solutions to these very serious problems and challenges. The COVID-19 pandemic struck suddenly. It has taken over 100,000 lives in this country, and it's caused a lockdown, resulting in 40 million job losses. Sadly, that's not the only story. COVID has hit the minority communities disproportionately. COVID has hit lower income Americans especially hard. COVID has targeted the elderly. COVID has taken a cruel toll on Americans with underlying health conditions like diabetes and cancer. We face an insidious evil enemy, but we face this enemy as a united country. We understand the grief. We work to flatten the curve. We understand that communities are trying to pull together to get through this. In my district, which includes parts of the city of New Orleans, we've lost over 1,300 of our friends and neighbors. More than 400 nursing home residents have died from COVID-19. Our largest hospital system, Ochsner, just reported this week that 77% of hospitalized COVID patients were African American. More than half of the fatalities have been minorities. The names and faces of COVID victims include people like a friend of mine, Ellis Marcellus, who's a legendary jazz pianist. He was an educator, and he's the patriarch of the Marcellus family. Through his fame, his death draws attention to the impact on the musicians, the artists, particularly in the African American community that represent so much of the culture and diversity and vitality of our city. Corona also tried to take Trishelle McDaniel from us. She spent 6 weeks on a ventilator. Immediately after giving birth, she was taken as she tested positive to be treated. When she emerged from a New Orleans hospital after 72 days, she finally was able to hold her infant son for the very first time. He was delivered when Trishelle first went into the hospital and was immediately separated for his safety. Her doctors called Trishelle a symbol of hope during a time of death and defeat. Nationally, COVID-19 deaths are nearly 2 times greater in minority communities than other communities. The Navajo Nation's, the country's largest reservation, now has a higher death rate than any U.S. state except for New York, New Jersey, Connecticut, and Massachusetts. In New Mexico, Native Americans are dying at rates 19 times that of all other populations combined. If we're going to do something about the disproportionate impact, we have to ask and try to answer why this is happening. We know this is not an American problem alone. All over the globe, minorities and lower income people have suffered disproportionately. In America, we do know that nursing homes and assisted living facilities have been places where COVID has spread and where too many people have died, including minorities. We can take immediate steps to reduce the suffering there by learning hard lessons that we've seen. Last week, this subcommittee heard from the mayor of Jacksonville, Florida, who laid out specific reasons why Florida has seen dramatically fewer deaths in nursing homes than, for example, states like New York. Let's hope the rest of the states follow those paths like Florida took and learn from the mistakes of states like New York. COVID mortality and diabetes appear highly correlated. African Americans have a disproportionate rate of diabetes. President Trump recognized this and moved recently to cap the cost of insulin at $35 a month for seniors. Last July, the president launched the Advancing American Kidney Health Initiative, which stated the goals of reducing the number of Americans developing end-stage renal disease, having more ESRD patients receiving dialysis at home, and doubling the number of kidneys available for transplant. Perhaps Congress should look at what we can do to help speed up achieving some of these goals. Finally, as we discussed last week, reopening the American economy is critical. The economic and health burden of the shutdown has definitely led to a disproportionate impact in minority communities. In my home state, almost 45% of the accommodation and food service workers have lost their jobs. This is an industry dominated by low-income and minority workers. Unemployment is closely associated with higher stress, more alcohol and drug abuse, and it leads to people delaying needed medical care. Getting people back to work is critical to improving healthcare outcomes, especially in minority communities. Mr. Chairman, we know we do not have all the answers, and some of the solutions take time. Operation Warp Speed, which the president kicked off, will hopefully bring those vaccines that we need soon. But we know it won't be today. So we need to keep working. But that shouldn't distract us from doing the things we know we can do to help things on the ground and to know that this administration and Congress need to continue working together to get this done. I look forward to a good discussion today from our witnesses. I thank them for joining us. And Mr. Chairman, I yield back.
I thank the ranking member for yielding back, and thanks to you once again. Let me thank our panelists once again and introduce the public health experts and community leaders who are with us today. First, Dr. Uché Blackstock is an emergency physician who has treated coronavirus patients in New York. She's also the CEO of Advancing Health Equity, an organization that helps healthcare providers to give equitable care to each and every patient. Dr. Leane Nguyen is a visiting professor at the George Washington University Milken School of Public Health and the former health commissioner for the city of Baltimore. Avik Roy is president of the Foundation for Research on Equal Opportunity. Then we will hear from Fawn, president of the National Congress of American Indians, an organization serving the interests of tribal governments and communities. We will then hear from Dr. Eva Galves, who is a family physician who has worked on the front lines of the coronavirus pandemic, treating migrant farm workers and other low-income patients in Oregon. Thanks all of you for being here today. And now I recognize Dr. Blackstock for her opening remarks.
Chairman Clyburn and subcommittee members, good morning. I am Dr. Uché Blackstock. Thank you for inviting me to speak at this critically important briefing on racial health disparities in the coronavirus crisis. I am an emergency medicine physician. I am also the founder of Advancing Health Equity. The mission of my organization is to work with healthcare and related organizations to close the gap in racial health disparities. I originally founded this organization prior to the coronavirus crisis because despite significant advances in healthcare and technology over the last decades, racial health disparities have been both profound and persistent. I would like to acknowledge the pain and trauma that many Black Americans are currently experiencing due to the recent killings of George Floyd, Breonna Taylor, and Tony McDade by police, and Ahmaud Arbery by 2 white civilians. Their deaths, like health disparities, are a symptom of the same deeply rooted disease in this country: structural racism and white supremacy. Black men have the shortest life expectancy. Black babies, the highest infant mortality rate. Black women, the highest maternal mortality rate. And this trend persists despite socioeconomic status and level of formal education. Even the chronic stress of living with daily racism results in the weathering effect, the premature physiologic aging of Black Americans' bodies. Living in this country has essentially made Black Americans sick. And over the last 3 months, we have witnessed a crisis layered upon a crisis, as Black communities across this country have borne the greatest burden of illness and death from the novel coronavirus. More than 1 in 2,000 Black Americans have died from coronavirus. If Black Americans had died at the same rate as white Americans, about 13,000 Black Americans would still be alive today. In mid-March, with my own eyes, I noticed the demographics of my patients in the urgent care clinic where I work rapidly shift from a racially and socioeconomically diverse population to mostly Black patients. Many of them were essential workers, bus drivers, subway conductors, grocery store workers. Many of them had underlying medical problems like diabetes, high blood pressure, and asthma. Many with no other choice than to use public transportation, and many displaying typical COVID-19 symptoms. However, we did not have adequate testing supplies at the time to test them. I've been a physician for 15 years, and I've worked in emergency departments with the sickest patients. I have never been as scared for my patients as I've been these past few months. In particular, I remember an elderly Black man who came in with shortness of breath and fever. His oxygen level was incredibly low. He lived by himself. I was very worried about him and told him I would like to call an ambulance to bring him from urgent care to the closest emergency room. He told me he did not want to go. He did not want to die in the ER. He told me he thought he would not receive good care, and he felt safer at home. As you all may know, this distrust among Black Americans for the healthcare system is not uncommon. It is based not only on a historical legacy of centuries of neglect, abuse, and exploitation of Black communities, but it's also based on current-day inequities. Structural racism through social and economic policies that disadvantage Black Americans have placed them at risk for illness and death. It has been the key driving force behind the factors that determine an individual's and a community's health outcomes. I urge this subcommittee to act urgently and swiftly to mitigate these widespread and appalling racial health disparities. This moment must be used for structural change in the form of, among other social determinants of health, safe and adequate housing, gainful employment, access to quality education and healthy foods, and healthcare for all. This country desperately needs a truth and reconciliation process around the racist policies, economic systems, and institutions that have left Black lives devalued. This is an opportunity to intentionally acknowledge unjustified and ongoing wrongs, engage with Black communities, and rebuild them equitably. And then maybe, just maybe, Black Americans, including my patient that I mentioned earlier, and my 2 little beautiful boys in the next room playing, could have more than a fighting chance against the novel coronavirus. Thank you.
Thank you very much, Dr. Blackstock. Now we hear from Dr. Nguyen.
Chairman Clyburn, Ranking Member Scalise, and distinguished subcommittee members, thank you for addressing the intersection of racial disparities and the COVID-19 pandemic. I come to you from the city of Baltimore, where I am a practicing physician and had the honor of serving as its health commissioner. In my city, children born today can expect to live 20 years more or less depending on where they are born and the color of their skin. There are racial disparities across every metric of health. And throughout the United States, the currency of inequality is years of life. There's a term in medicine called acute on chronic. This is what we're seeing with COVID-19. It's a new disease that has unmasked long-standing health disparities among African Americans and other minorities who now bear the greatest brunt of this pandemic. My written testimony outlines solutions to address both the acute issues and underlying problems, and I'd like to highlight 4 concrete actions for Congress here. First, the federal government must target public health resources to minority and underserved communities. I want to talk about testing, not only that it needs to be widespread and free, but also that demographic information must be available for testing as a way to track resource allocation. Let's say that we see the positive rate in a community is 10%, but African Americans are testing positive at 20%. That means African Americans are under-tested. My ideal scenario is for the CDC to post a real-time dashboard on testing to ensure that resources are directed to communities most in need. Also, our guidance for someone who tests positive is to self-isolate. Well, what do you do if you live in crowded, multi-generational housing and you have to do something that's impossible, while also losing your ability to earn an income? I've joined with other public health leaders to call for unused hotels and dormitories to be converted into voluntary self-isolation facilities and to replace wages with a small sum like jury duty. Second, the federal government must ensure that there are clear directive guidelines to protect workers. As a former local health official, I depended on the CDC for unambiguous guidance when I dealt with measles, Ebola, and Zika. Something has changed. The language in the COVID-19 guidelines is not what I'm used to seeing from the CDC. People should not just be, quote, encouraged to do social distancing. What exact standards must be met in office environments versus meatpacking plants? Masks should not be worn, quote, if feasible. They should be required. I want to see a clear statement such as, if these 15 criteria cannot be met, they cannot reopen. OSHA should then enforce these rules, as should local and state regulatory entities. If not, it's people of color and those who already face systemic disparities who will suffer the most. Third, the federal government needs to implement a national strategy to prepare for the next surge. It's a national shame that we ran out of masks and other PPE to protect our healthcare workers. There was no excuse last time, and there should be no excuse moving forward. PPE should not only be available for doctors and nurses. Why shouldn't cashiers, bus drivers, and nursing home attendants, who are disproportionately people of color, also have protection? And there must be a framework, too, for thinking about equitable distribution of treatments and vaccines should they become available. Fourth, Congress must provide further support for local public health. CDC funding for public health preparedness has been cut by half over the last decade, forcing local officials to make impossible trade-offs between critical programs. I think we can all agree that treating COVID-19 should not come at the expense of preventing cardiovascular disease and reducing overdose deaths. Longer term, there must be attention to how health disparities are inextricably linked to housing instability, food deserts, and lack of transportation access. And there needs to be recognition of the fact that racism is a public health issue, indeed a public health crisis in and of itself. I'd like to end my testimony today with a quote from the former chairman of the House Oversight Committee, the late Representative Elijah Cummings from Baltimore. He would talk about the work we have in front of us as bigger than us, so much bigger than us, that it's about our children who are messengers to a future that we will never see. That future is one in which the currency of inequality no longer equals years of life, one in which where people are born and what race they happen to be no longer determines whether they live. Thank you.
Thank you very much, Dr. Nguyen. We'll now hear from Dr. Roy.
Chairman Clyburn, Ranking Member Scalise, and members of the House Select Subcommittee on the Coronavirus Crisis, thanks for inviting me to speak with you today. The Foundation for Research on Equal Opportunity, or FREOP for short, focuses exclusively on policies and ideas that can improve the lives of Americans on the bottom half of the economic ladder. Consistent with our mission, we've spent the last several months focusing on the impact of COVID-19 on lower-income Americans of all races and ethnicities, and we welcome the opportunity to discuss our research specifically on minorities with you today. My written statement contains a more detailed discussion of our findings. In my oral remarks, I'll focus on 3 topics. First, I'll discuss the mortality impact of COVID-19 on major U.S. racial and ethnic groups. Second, I'll discuss our research on a critical subpopulation, vulnerable seniors who live in nursing homes and assisted living facilities. Third, I'll discuss how economic restrictions put in place by states and localities have disproportionately harmed minorities. We have good reason to believe that minorities are at higher risk for COVID-19. Severe illness and death from COVID-19 are associated with patients with pre-existing cardiovascular or metabolic conditions such as high blood pressure, heart disease, and diabetes. These conditions are disproportionately prevalent in African Americans, for example. The latest COVID-19 mortality data from the CDC indicates that indeed, Blacks represent a greater share of COVID deaths than they do of the general population, even when adjusted for the fact that COVID is more prevalent in cities. What may be surprising is that whites are also dying of COVID at higher than predicted rates. On the other hand, Hispanics and Asians represent a lower share of COVID deaths than would be implied by their geographically adjusted share of the US population. The likely reason for these differences is that morbidity and mortality from COVID-19 is most common among the elderly. 81% of all COVID deaths in the US have occurred in people aged 65 or older, and whites are the oldest racial group in the US with a median age of 44. Asians have a median age of 37, Blacks 34, Hispanics 30. Hence, we should expect to see higher fatality rates in whites relative to Asians and Hispanics due to their age, and indeed we do. On the other hand, African Americans are relatively young, but we are seeing higher mortality rates among Blacks. We'll have better data with which to assess racial disparities in COVID mortality when the CDC releases data that breaks down mortality rates by race and age at the same time. My understanding is that such data is forthcoming. You may be familiar with research that we've produced over the last several weeks on the tragedy taking place in our nursing homes and assisted living facilities. 0.6% of Americans live in long-term care facilities, and yet within this 0.6% of the population lies 42% of all US deaths from the novel coronavirus. 42%. As you know, nursing homes are residential facilities for medically vulnerable seniors who have challenges with activities of daily living, such as taking a shower or getting dressed. Nursing home residents are disproportionately poor, non-white, and enrolled in Medicaid. So my FREOP colleagues Greg Gervin, Mark Dornauer, and I wanted to see if states with high death rates in long-term care facilities were also associated with high proportions of Black residents or residents enrolled in Medicaid. As my written statement details, we found no such correlation. Once again, a more granular analysis based on county or facility level data may yield greater insight, and we expect that CMS will be producing that data in the coming weeks. There is no such ambiguity regarding the results of the economic lockdowns that states and localities have imposed on people and businesses in response to the pandemic. In late 2019, Black unemployment reached its lowest rate in history, 5.4%. Today, the Black unemployment rate is 16.7%. Hispanic unemployment reached 3.9% in late 2019, also a record. Today, it's 18.9%. Compared to whites and Asians, Blacks and Latinos are less likely to work in white-collar occupations where working from home is feasible. Instead, they're seeing their jobs and hours slashed. Hourly wage work is down 50% on average, and even more in places with the most stringent lockdowns. The decision to impose lockdowns may have made sense in mid-March when we feared that our ICUs and hospitals would be overwhelmed like Italy's were. But within weeks, it was clear that evidence-based reopenings could protect public health and restore employment for low-income Americans of all races. In mid-April at FREOP, we published a plan called A New Strategy for Bringing People Back to Work During COVID-19 that details exactly how that can be done. And I'm glad to say that a number of states have reopened in the ways we recommend. Reopening is not just important for the economic health of minorities, but also for our physical health. Think of all the cancer screenings and heart attacks that have gone undone and untreated because we've been told it's unsafe to leave our homes. We can do better, and I look forward to working with this subcommittee to get there. Thank you very much.
Thank you very much. We will now hear from Ms. Shaw.
Oh, Kiyohich. Good morning. My name is Fawn Sharp. I serve as president of the Quinault Indian Nation and president of the National Congress of American Indians. Chairman Clyburn and ranking member Scalise and members of the subcommittee, we thank you for convening this hearing. We look forward to partnering with you in the future to address the disproportionate impacts of COVID-19 to our communities. Like all other governments, tribal nations work hard to keep our communities safe, healthy, and strong. We have noted for centuries that our relationship with the United States is one that is born out of treaties. We've entered into sacred agreements whereby we ceded millions of acres of land. In exchange, the United States made sacred promises to provide for the health care for our communities. For over 200 years, the United States has recognized their trust and treaty responsibility and commitments to provide for our health care. Despite this fiduciary responsibility, the United States has chronically underfunded every sector of our health and socioeconomic life, creating a crisis in the 21st century that deeply affects our public health, our economy, and our social life. These disparities has led to the vulnerability of our community during this pandemic, and it's resulted in our communities having the highest per capita COVID rate in the United States. Currently, we are looking at not only the impacts of chronic underfunding, but the vulnerability that has led to our communities to having some of the highest rates in the United States. Presently, the rate of infection and deaths from COVID-19 continues to grow in our communities. The Indian Health Service reports that nearly 11,475 positive cases within the Indian healthcare system. According to the CDC, over 395 natives have died. And in some regions, the impacts are even deeper. In New Mexico, for example, we represent only 11% of the population, but we are impacted at a rate of 43.7%. In Arizona, we are 2% of the population, but we are impacted at a rate of 21.6%. Well, Stark, these statistics undercount the extent of COVID-19 to our communities due to data collection issues. For example, IHS does not keep data on hospitalization and mortality data for our communities within the Indian healthcare system. Second, the inability of our community to access testing and our limited resources. Third, 71% of our population lives in urban areas, and data collected by local healthcare authorities often omit and misclassify us. Compared to other groups, we have disproportionately high rates of diabetes, heart disease, and asthma, as well as health conditions that serve to provide a lethal impact to our communities. Similarly, tribal communities experience overcrowding homes at roughly a rate of 8 times the national average, which makes quarantining and social distancing nearly impossible. Additionally, lack of access to water and sanitation has been a long-standing public health challenge for our communities. Over 31% of homes on tribal lands are in need of sanitation facility improvements, while 13% of native homes, in contrast to only 0.6% of non-native homes, lack access to safe drinking water. These disparities are a byproduct of the underfunding of the federal government's trust and treaty responsibilities. With regard to health, IHS services over 2.2 million individuals, and in 2018, IHS expenditures per person were $3,779, compared to $9,409 for federal healthcare spending nationwide. In December of 2018, the U.S. Commission on Civil Rights released a report entitled The Broken Promises Report, Continuing Federal Funding Shortfall for Native Americans, which found that federal programs continue to chronically underfund. And with regard to healthcare, the Commission found 2 things. First, as a result of the failure to honor the federal trust responsibilities, vast health disparities exist in Native communities and populations. Second, funding for tribal health is inequitable compared to other federal health spending and covers only a fraction of tribal healthcare needs. Indian country has experienced unquantifiable harm during this pandemic. The death of each tribal citizen has meant the loss of part of our culture, our history, our language, and devastated many families where multiple members have died. We must structurally address health disparities to prevent this devastation from reoccurring. The Broken Promises report effectively laid out a Marshall Plan or a roadmap for addressing a pre-COVID health and socioeconomic crisis in tribal communities. Now more than ever, such a plan is needed to address this pandemic and the conditions that created it. I urge this subcommittee to aid in the development of a public health and economic recovery plan by working with the U.S. Commission on Civil Rights to supplement the Broken Promises report by evaluating the conditions that led to COVID's growth in Indian country, the impact of legislative and executive branch responses, and propose legislative and administrative solutions, including technical fixes, that could be adopted to address the disparities identified in an updated report. I also urge the subcommittee to aid Indian country by exercising its powers to address delays in federal funding that were specifically allocated by Congress for the COVID response. Tribal nations have experienced delays in accessing HHS, CDC, and DHS funding. Further, and to date, over 2 months after Congress passed the CARES Act, over $3.2 billion of tribal COVID funding has yet to be released by the Department of Treasury, Education, Interior, Agriculture, and Commerce. As a result, I urge this subcommittee to investigate these delays to ensure that congressional COVID relief immediately reaches our communities. I thank you for your time, and I'm happy to answer any questions. See you, Will.
Thank you very much, Ms. Shomp. We're going to take a short pause here. It seems as if we're having some technical difficulties. I think I see the ranking member. Are you back in, Steve?
Yeah, I know they said there were some technical difficulties with the video. Do you know if that's working now?
I see you.
Okay. Yeah, obviously.
I do not see our next
challenge. Yeah.
Next witness was Galves. Galves, I not see her. I hear something.
This is Dr. Galves. Can you hear me?
Yes, can hear you now.
Yes. Good afternoon, Chairman Clyburn and members of the subcommittee. See me?
Yeah. Can't see you, but I hear you.
Good morning.
Good morning.
Good morning, everybody. Sorry
I now
about the
see you.
technical difficulty. You can see me now. Good afternoon, Chairman Clyburn, the subcommittee. I'm Dr. Galves. I'm a family physician at Virginia Garcia Memorial Health Center, and I am so honored to be here today. I'm also the proud daughter of a Mexican immigrant and seasonal farm worker. My life experiences, along with the work I do today, have provided me with a unique perspective on the challenges faced by Latino immigrants and farmers. This pandemic has laid bare the essential contributions that Latino immigrants and farm workers are making to our country. For the past 10 years, I have worked on the front lines as a treating physician at Virginia Garcia. We are a federally qualified community health center serving more than 52,000 individuals every year. Over half of our population is Latino. 98% of our patients live the poverty line, and 20% are farm workers. Our patients are some of the most vulnerable in the community. Lack of access to appropriate housing and health care, food insecurity, and unsafe working environments all contribute to their higher rates of diabetes, respiratory issues, and lower life expectancy. COVID-19 continues to expose the heightened challenges and increased vulnerability our community faces. While Oregon has seen a decrease in the infection rate, the positive rate among Latinos in the state has increased. In Oregon, Latinos represent approximately 13% of the population, yet we are 30% of the positive cases. I offer you a closer look at the Virginia Garcia data. As of June 2nd, we tested 1,418 individuals. Just over 60% of those tested identify as Latinos, yet they represent 92% of the positive results. Oregon is not alone in this disproportionate rate. The nation, Latinos account for 32.7% of the positive testing results, but only 18.2% of the population. So what are the factors contributing to this disparity? Latinos make up a large portion of our essential workforce. Laboring to keep food on our tables, they work in agriculture, nurseries, and food processing plants. These jobs, while intensely physical, take place both indoors and outside, and often require work in crews or groups standing side by side in rows or on factory lines. Most often they are without PPE. A patient came to me in late April asking to be tested. She was asymptomatic but had found out her coworker had tested positive the day before. She shared with me that up until recently, she continued to work elbow to elbow with her coworkers. She had not been wearing PPE during this. Her employer told her that if she wanted PPE, she would need to test it herself and they would reimburse her later. It was not until an anonymous report was made to OSHA that changes in her working environment were made. Even then, her employer expressed frustration over the required changes, and she was fearful that there would be retaliation. Adding to this, most Latino immigrants and farm workers do not have access to unemployment benefits, vacation, or paid sick leave. If they begin to experience symptoms, they go to work anyway because if they do not work, their family does not eat. 3 weeks ago, I tested a farm worker exposed to COVID-19. He was a single father of 2 young daughters with no family in the area. Although fearful of the prospect of infecting his daughters, even more distressing to him was the loss of income and finding alternative housing if he had to be quarantined. Complicating matters, crowded living conditions contribute to the spread of this highly contagious virus. Many farm workers that live in labor camps are housed with multiple unrelated individuals, sleeping and living in one room no bigger than a 10 by 10 space. In some labor camps, you will find a single washing machine for 30 people and one shower shared by 10 people. For those who live outside of labor camps, their low wages make finding affordable housing a challenge. Often multiple families live in apartments designed for single families. This reality presents a massive barrier to observing social distancing and make it nearly impossible to self-quarantine if someone does fall ill. All of these things, working conditions, lack of basic benefits, and living in close quarters have facilitated the spread of the virus and led to the disproportionate burden of COVID-19 on this already vulnerable population. I'm here today to ask this committee to address 3 things: workplace protections to promote a safe and healthy work environment, expansion of worker benefits such as healthcare for all, unemployment and sick leave for all workers considered essential, improvement in labor housing for farm workers in labor camps. I ask you today to join me and other healthcare advocates in creating solutions that will ensure safe working and living conditions for this vulnerable, essential population. Thank you.
Well, thank you. Thank you very, very much. We have heard now from all of our briefers here today. And before I turn to the ranking member to offer any questions you may have, I want to ask Dr. Blackstock, do you have any specific suggestions you would like to make to us as to what you think we need to do in order to address the issues that you have raised here today?
Absolutely. So there are strategies that we can employ in the short term and in the long term. It's very clear to me that this pandemic will be with us for some time, and I think we can mitigate some of the devastation by doing several things. One, we need to equitably allocate resources to Black communities as quickly as possible, and we know now that testing and contact tracing and isolating sick individuals are really some of the key fundamental public health intervention strategies that we can do. In terms of testing, it's not just about testing, but ensuring that it's accessible. So walk-up testing, mobile testing needs to be available in Black areas. Contact tracing in itself is a very sensitive area because when you contact trace somebody, they will have to tell you exactly who they've been in contact with. For that, we need to make sure we are engaging with Black communities. And so I see a role for peer educators or community health workers really to be involved in the contact tracing efforts. Messaging and outreach will be incredibly important because the distrust that we have in Black communities towards the healthcare system is going to be an issue in terms of access, and then later down the road in terms of vaccine. And then, as I think Dr. Wen mentioned, ensuring that our essential workers not only have personal protective equipment, but also have hazard pay and financial assistance for lost wages will be key, as well as ensuring that food banks are well supplied and that we are addressing housing instability needs of these communities. Longer term, we're going to need very profound investment in Black communities around the social determinants of health that we talked about previously. And that's, housing, education, and jobs, and ensuring that we create policies that are we're using a racial equity lens to examine these problems. Thank you.
Thank you very much. I know there's a question on the forward of Dr. Wen. Would you like to add to that, Dr. Wen?
I wholeheartedly agree with what Dr. Blackstock said in terms of the access issue. We already know what works when it comes to public health infrastructure to combat COVID-19. We know that we need testing, contact tracing, quarantining, isolation. That these are the pillars, if you will, of being able to contain this disease. And that, of course, we also need treatment as well. And all of that needs to be accessible. So you cannot just it is necessary but not sufficient to make these types of things affordable. We definitely need it, ideally, the testing, tracing, et cetera, to be free, but you also need it to reach people where they are. That communities that are the most underserved. And for me, having worked in Baltimore, I can tell you that for many of our residents, they're not going to necessarily go to their doctor's office or their hospital in order to get a test. That testing needs to be brought to them, ideally to places like churches, to public housing, to other places where they are, in order for it to make a difference. And then on top of that, we need for there to be data and surveillance that accurately capture demographic information so that we can tell, again, if testing is not targeted to communities of color and we're under testing in certain communities, we can immediately identify that problem in real time and target our resources and interventions accordingly.
Well, thank you both very much. I really, really appreciate what we've heard from all of our panelists here today, and I am sure that all the members will agree that you've given us a whole lot to work with. And with that, let me yield to Ranking Member Scalise.
Okay, thank you, Mr. Chairman. And, as we're looking at the data, obviously, we're seeing in the United States, there's definitely a disparity. African Americans are more than 2 times more likely to die from COVID-19 than in white communities. When you look around the world, some places it's hard to get data, but let's say the United Kingdom, for example, we are seeing data there that shows it's even worse, where it's maybe 4 times more likely that someone die in the Black community there than in the white community. Dr. Roy, I know you've done some research on this, and while data is not as widely available in all countries, from the countries you've been able to get data on, are you seeing a similar racial disparity all around the world?
Well, what's important to remember when you look at the data is that COVID, like many infectious diseases, is going to be more contagious. It's going to spread more rapidly in highly dense communities. In other words, cities. So you have to adjust the statistics for where somebody lives. So, for example, in the United States, the tri-state area around New York City represents more than half of all COVID cases and deaths in the United States. And the Northeast corridor from Virginia to New England represents an even greater share. Right. So if you actually then, and the CDC does this in the statistics they publish every day, which is what we based our analysis on. If you actually adjust the baseline demographic you're comparing to that fact. So, for example, who lives in New York City? What's the demographic composition of New York City? And then compare that to the death rates by race and ethnicity in New York City. That's the analysis that we've presented for you today. And based on that analysis, and that's to your question, Mr. Scalise, that's something that you do see internationally as well, because it's also we're seeing there's regional variation, of course, but urban and dense environments are a part of the equation. So if you actually adjust for geography, you get to the statistics I mentioned, where the African American mortality is an outlier relative to other races and ethnicities in particular, and I think that's where we'll need to address more of our interest, along with the issue of nursing homes that I discussed in my opening statement.
Yeah, and I know I want to ask you about nursing homes too, but before we get off of this, especially within the African American community, we've seen on the economic side, and you touched on this in your opening statement, that the economic shutdown has had its own set of negative health consequences through all populations. As you mentioned, people aren't getting their cancer screenings and their mammograms and some of the other things that they would do to take care of themselves physically. That's not happening, as well as mental health issues that aren't being addressed. Are you seeing that disparity in the African American community as a direct result of the economic shutdown?
In terms of, if your question is what's the data around racial disparities in terms of declines in screenings and treatment of heart attacks and things like that, we don't have enough data yet to make firm conclusions, but we certainly, based on what we already know, can be very concerned, right? Because we know that heart disease, high blood pressure, diabetes, et cetera, are more prevalent in the African American community, and therefore the lack of ability to manage those chronic diseases and sometimes acute conditions is very problematic. So I'm very concerned about that, and we are at my institution.
Well, thank you. I know we're putting additional resources. Hopefully they can be directed properly to address this. Finally, you did touch on the nursing homes. We talked about this in last week's briefing, where you saw a very high disparity. I think 42% of all COVID deaths in the country are amongst nursing home patients, which only represent about 0.6% of America's population. So clearly there's a problem. But as we saw, not all states are doing this the same way. And in some states, they're doing it well. Florida, the mayor Jacksonville was here, talked about the success they had because they put good protocols in place. And of course, we all saw the highest incident was in New York, where the governor, for whatever reason, mandated that nursing home patients or that COVID positive patients in hospitals have to go back to the nursing homes, even if they couldn't properly take care of them in a quarantine situation. And that led to tragic deaths. You studied that. Have you seen that as well?
So it's a huge problem, the fact that certain states, and New York isn't the only one. New Jersey did this. Michigan is doing this still. At least New York, they finally reversed course in mid-May. But New Jersey and Michigan are continuing these policies. And in Michigan, we don't even know what the death rate is for nursing homes, because Michigan refuses to publicly disclose the death rate for people living in assisted living facilities and nursing homes relative
That's unbelievable. I mean, and that's something maybe we can address here in this committee, because people are dying for no reason. I mean, we know enough now to know there is a better way to take care of nursing home patients, especially COVID positive. That's completely senseless deaths that we can hopefully focus on addressing and confronting. But and I'll let you finish. I apologize.
Yeah, no, it's great. So it's the one positive note, I suppose, is that CMS is now requiring nursing homes to directly report fatality statistics to CMS, starting with May 5th data. So we won't have data necessarily prior to May 5th unless nursing homes voluntarily report it. At least from May 5th onward, we should have more consistent reporting across geographies on this problem. And that should
Thank you for
also
that.
highlight the racial disparities, because we should get that demographic data.
Thank you.
Absolutely. Thank you, Mr. Chairman. I yield back.
Thank you very much. The chair now recognizes Ranking Member Woters. Chairwoman Woters.
Thank you so very much, Mr. Clyburn. I thank you for holding this hearing. This is extraordinarily important. And I guess I get somewhat very, very upset with this constant talk about health disparities because we've been talking about health disparities for years. All of these minority populations die from preventable diseases, and this is traditional, historic. I mean, this has been going on. And so it's no surprise that minorities are dying in this pandemic because of pre-existing conditions. And so we talk about what nursing homes can do, for example. If you have been to nursing homes, you know what the problems are. First of all, you're absolutely correct. The poorest people with lots of pre-existing conditions are in nursing homes. A lot of Blacks in nursing homes. By the time they get to a nursing home, they've had diabetes, they've had amputations, on and on and on. And so when you talk about what we can do, they can't do social distancing in nursing homes. They can't do quarantine in nursing homes. They have the lowest paid workers, and their turnover is very high because they get anybody they can get, people coming off the street, etc. So when you talk about what we can do in nursing homes, you really have to be talking about money. We need resources. We need to invest more money in the care of these patients in nursing homes. And so whether we're talking about nursing homes or we're talking about African Americans, Latinos, Indians, etc., what we need to be talking about is, in some shape or form, Medicare for all, even without a pandemic. So the pandemic is here, and much of what is being talked about as ways to respond to it, if you really understand and know and had the experiences, you know a lot of it is simply speculation about what can be done in order to save these people in nursing homes. Of course, we need testing. Of course, we need isolation. Of course, we need quarantine. But how many of you will agree we need lots of money, and the government should spend the money to do what is necessary for Medicare and protection for all, even when there's not a pandemic, and in the pandemic, spend the money that is needed to access additional spaces so that we can take care of people properly. How many believe that we just need to spend the money in America? I'll start with Miss Blackstock.
Hello. Hi. Yes, no, I agree. I think that the solution is sustained commitment at all levels of government to address living and working conditions in Black communities. And so whether that's looking at Medicaid expansions, funding community health centers, because we know healthcare is moving out into the communities.
Okay, well, let me just go right down the line. Dr. Galves.
Yes, Chairman.
Are you willing to indicate that we just need the resources, the money to deal with these problems?
Absolutely.
The government needs to spend whatever it needs to spend. Ms. Sharp, do you believe that?
Yes, absolutely.
All right, Dr. Nguyen?
Yes, we know what works. We just need the funding to be able to get there, targeted to areas of greatest need.
Okay, and the Foundation for Research on Equal Opportunity, President Avik S.A. Roy. What do you think?
We need resources, but we also need way better infection protocols, and we need much better oversight over nursing homes, because we've seen a lot of problems where nursing homes aren't actually doing what they're legally required to do.
They can't do it. You know why? Because they're doing it on the cheap. And when they talk about feeding lunch, for example, in a nursing home, there's no place to go except in this one space where they all gather. And so they don't have, all the rooms are filled. They don't have any place to isolate. So what are we talking about in terms of we have allowed nursing homes to develop on the cheap, and we're not putting the money into nursing homes that it takes. We can't protect these patients in the way that nursing homes are constructed and the amount of dollars that they have to spend on them at this time. Are you aware of that?
Yes, I am aware of that, and I do agree that resources are part of the problem. As part of actually what I would say, Madam Chairwoman, is we need to do a better job of making Medicaid more flexible so that people aren't required to get supportive care, long-term care in a nursing home. It would be much better if Medicaid were more flexible so that people could get that supportive care in their own homes instead of in a facility. But Medicaid doesn't always allow that flexibility.
We've got to
That's not a
stop
resource question.
We got to stop dumping our elderly into these nursing homes that don't have the resources to take care of it. Thank you. I yield back.
Much. The chair now recognizes Congressman Jordan.
Thank you, Mr. Chairman. Let me thank our witnesses for being here today. Dr. Roy, why did we shut down the American economy 3 months ago?
Well, there are a lot of different reasons that people supply, but the reason that was most persuasive was that we were worried that we would overwhelm hospital and ICU capacity if the pandemic spread too widely. And so we had to shut down to prevent ICUs and hospitals from being overwhelmed.
Did we accomplish our goal?
Yes.
Was there harm associated in that shutdown for the American people?
Incredible harm, catastrophic harm.
Both economic harm, obviously. When people tell you can't operate your business, there's a harm, there's a cost, there's an opportunity cost, there's a lost, there's all kinds of costs associated. But there was also cost. I think you said this in some of your references in your opening statement. There was also health concerns for Americans because of that shutdown.
Yes, and it will take us years to unravel exactly what those costs are, but they are significant.
And I think you said in your opening statement, the economic costs and the healthcare costs, or the health concern costs to Americans, there was a disproportionate impact on the African American community. Is that accurate?
Yes.
Is it now time to reopen our economy?
It's way past time.
So let me ask you this: in states that have largely opened up and did so early on, what has been the health concern? Has there been greater contraction of the coronavirus in those states relative to states that are largely still closed?
By and large, and I'm sure, Mr. Jordan, you're probably familiar with this data, we are seeing no difference between the states that are continuing to lock down, the states that are opening up in terms of overall, on average, declining deaths and morbidity.
So why in the world are some states still closed and some mayors still adopting the policies that we see in place in some of these areas?
Well, I suppose, Mr. Jordan, you'll have to bring them before your committee and ask them yourself. But clearly, there's a wide range of opinions about what to do. We clearly should be looking at the states that are reopening.
Dr. Roy, from a health standpoint, there's no data that supports remaining closed. And certainly from an economic standpoint, there is no data that supports remaining shut down.
Well, let's put it this way. The evidence is overwhelmingly that we should have a targeted approach where we're very focused on what's going on in nursing homes. We're very focused on at-risk populations like people with heart disease, the elderly, et cetera. But we should absolutely be reopening schools. We absolutely should be letting younger people back into the workforce who are at much lower risk.
Yeah, no, I appreciate it. And I want to read you a letter that was sent to the president on March 19th, 2020, back to the health concerns that exist when you have a shutdown. 500 physicians sent this letter to President Trump. And I'm quoting from it. It says, millions of casualties of continued shutdown will be hiding in plain sight, but they will be called alcoholism, homelessness, suicide, heart attack, stroke, or kidney failure. In use, it will be called financial instability, unemployment, despair, drug addiction, unplanned pregnancies, poverty, and abuse. You think that statement's accurate?
Yes.
And all the more reason why we need to open up our economy yesterday, in my judgment, and get back to normal as quickly as we possibly can.
One thing we talk about in our major paper on reopening at freeop.org is that the average small business has less than 30 days of cash in reserve if they have no customers. So we're seeing already hundreds of thousands of small businesses, many minority owned, by the way, permanently closed because they don't have the cash reserves to reopen once we get out of lockdown.
Best way we can help Americans, all Americans, African Americans, all Americans, is to open up our economy and let people go back to doing the things they need to do. From a health concern point of view, that statement is true. And from an economic point of view, that statement is obviously true.
Absolutely.
Thank you. I yield back, Mr. Chairman.
Thank you very much, Mr. Jordan. The chair now recognizes Ms. Maloney.
Thank you, Mr. Chairman, and thank you to all my colleagues and also to all the panelists. We are suffering from inequality in our justice system and in our healthcare system. As in many places across the country, communities of color in my home of New York City have been hit the hardest by the coronavirus pandemic. In New York, more than 6,100 Black and African American residents are estimated to have died from the coronavirus, and more than 6,300 Hispanic and Latino residents are estimated to have died. And according to the Center for Disease Control, Black New Yorkers are dying from coronavirus at twice the rate of white New Yorkers. And lack of testing, which has been one of the deadliest missteps of this administration, has disproportionately impacted the African American community here in New York City and elsewhere. So I'd like to ask Dr. Blackstock, how did lack of accessible testing affect infection rates in New York City, and who was left behind?
Thank you for that very important question. I'll say, even from my own personal experience caring for patients during the pandemic, we were unable to test them for weeks. I was probably giving two swabs for probably about 100 patients per shift. And when I think about all of the patients that we missed because we were unable to test them, and they went back out into the community not knowing whether they were infected, absolutely contributed to the high rates that we saw. And the issue is that if we rush to reopening, we are going to get into the same predicament we got into in the beginning, and it may even be worse. And the people that are going to be most disproportionately impacted are the same communities. Black communities and other communities of color are going to see even more devastation. And so what we need to do is be able to support these communities, individuals, small businesses through a shutdown so that we can get this virus to die out, and then we can reopen safely. But right now, we don't have the testing infrastructure or contacting tracing infrastructure in place to do so safely.
Well, New York is now launching a testing and tracing program that recommends testing for every single New Yorker. But even when testing is available, it may not be accessible. For instance, many people in the African American community have a distrust of the healthcare system and may not seek testing, as some of you testified. So Dr. Blackstock, what is the root cause for this distrust, and how does it affect health outcomes for the African American community?
This distrust is very real. I had a patient a few weeks ago who, she couldn't see me under my layers of personal protective equipment, a young Black woman with COVID-19 symptoms, who whispered to me, "Are you Black, doctor?" And I said, "Yes." She said, "Okay, I just want to make sure that I'm being listened to." Okay, so this is not just a one-time thing. And so this distrust is a result of this historical legacy of racism in this country, where, especially in terms of Black communities interacting with the healthcare system, there's the Tuskegee experiment, there's Henrietta Lacks, there are many, many instances in history. And so this distrust is very important to repair. And so we're going to need, I would even say, not just resources, but even reparations to Black communities in order for them to not only survive, but thrive.
Thank you. Now, for the Latinx community, we've seen a language barrier to testing when information on the coronavirus is only released in English. So I'd like to ask Dr. Galves, how has the lack of public health information in Spanish contributed to testing disparities in the Latinx community?
Well, at my community health center in my community in Oregon, what we noticed in early March when we were just finding out about COVID-19 was that the information that was being provided was primarily in English. And so you have to remember that for the patients that I see, they are primarily Spanish speaking. Some of our patients actually don't speak Spanish, and I think we tend to forget that. We have many of our essential workers and migrant farm workers that are actually speaking indigenous languages as well. And so we noticed early on that this lack of information in Spanish and language was definitely contributing to decreased knowledge about how to mitigate spread of the virus. But in my community, we immediately noticed this and we began to create public service announcements in Spanish that were both given on the radio and written. And we noticed that within about a couple of weeks, the public began to have a better understanding of how to mitigate the spread of COVID-19. And my concern is that many of my patients, by the time we were in late March, they did have the information that they needed in order to prevent spreading the virus, but they do not have the support systems at work. And I go back to the point that I made. People can have information and knowledge, do not have the support systems in place at their work sites. They are not to be able to implement these healthy behaviors. The same goes for housing and labor camps. We can give them PPE when they are on the field. However, if they go home, they continue to live in these crowded camps, they will still spread the virus. And so I'm asking that we really pay attention to the conditions at work, but also to the housing conditions that my patients are living in.
Thank you very much, Ms. Valquez. And thank you very much, Ms. Maloney. The chair now recognizes Congressman Lucamaya.
Thank you, Chairman Clyburn and Ranking Member Scalise, for getting putting the hearing together today and the interesting panel that we have here. As we go through the process of trying to look at the effects of the COVID on our entire population, and you look at the disparities between those groups that are being more or less impacted than others, and economically the same impacts. Dr. Roy, have you done any studies with regards to vaccinations? I know that there's some governors that believe that, and some mayors that believe we can't get back to work until we get a vaccine. And they believe late fall, early winter, we may have a vaccine now, but we can't be shut down till then. I think some of the other members have already discussed the fact that, and in fact, I think in one of the publications just a week or so ago, that the number now is 65,000 people per month die from the result of the COVID effect, not from the COVID disease itself, but from the effect of focusing on COVID at the expense of the rest of our society. And so if we don't focus on those folks pretty soon, we've already gone past the COVID deaths with those deaths of people who we have not been paying attention to health-wise. If we continue that, it's going to be devastating to our economy. But believing that you have to have a vaccine, to me, is a false sense of security standpoint. There's a recent study that came out that said over 50% of the people, if a vaccine was available, wouldn't take the shot. How do you address that issue? How do you incentivize those people? How do you get past this issue? And then because of that, it would seem that it's even more imperative that we open up our economy. Would you like to comment on that?
Well, I really appreciate you bringing this point up because I think it's one of the most reckless policy postures in this crisis to say we're going to wait for a vaccine before we reopen the economy. And the reason why is that there's absolutely no guarantee that we'll have a vaccine in the next 12 to 18 months. We've been working for nearly 40 years on a vaccine for HIV. We still don't have one. We've been working for even longer on a vaccine for hepatitis C. We still don't have one. Now, we have effective drugs that treat active infections for HIV and hepatitis C, but we do not have vaccines. We've never developed a vaccine for a coronavirus before. The land speed record for a novel virus developing a vaccine was the Ebola virus. It took us 5 years to develop a vaccine for the Ebola virus. Now, look, there are very talented people, very brilliant people, lots of entrepreneurs trying to solve this problem. And maybe they'll succeed where others have failed. But there are absolutely no guarantees. And we cannot keep the economy locked down until a vaccine that may or may not ever come.
I know you've had a lot of statistics a minute ago with regards to unemployment. The relationship between disease and unemployment is certainly something I've been doing a lot of reading on. I mean, we see increased suicides, alcoholism, drug abuse, deaths from drug overdoses, domestic abuse, all of those things. And it would seem that an active and ongoing economy would certainly take care of a lot of these things. Does your research show that when economies pick up, those things actually slow down?
Yeah, there's a lot of research now, cumulative research about the negative health effects of unemployment and poverty. The one countervailing thing is if you lock down the economy, nobody's getting into a car accident. That's the one thing that goes in the other direction, but everything else is negative. So it's a huge problem, and that's why it's very important. I think there's been this false dichotomy that's been sometimes put out there about, well, if you care about reopening the economy, you only care about money. No. Reopening the economy is essential for public health, because if people are afraid or are told they should be afraid of leaving their homes, they're not going to see their doctors. They're not going to get those mammograms. They're not even going to get treated for a heart attack. And that's really, really important.
You know, it's very interesting. One of my colleagues on the committee, I think last hearing, made the comment with regards to masks. And I pulled that New England Journal of Medicine letter or article up, and I presented it to some health professionals in my district. And they all agreed that wearing a mask outside of a healthcare facility offers very little protection and is actually probably not worth your time or your money to do that. It seems to me that these false things that people are putting out to try and control people seems to be backfiring. And I think people are getting the information out there to show that they can live their lives in a very productive way, in a very normal way. And I think that's the message we should be sending. Thank you very much, Mr. Chairman. I yield back.
Thank you very much. The chair now recognizes Congressman Foster.
Well, thank you, Mr. Chairman, Mr. Ranking Member. Yes, I too had a look at that New England Journal of Medicine, the article that was referenced in the last thing. It was interesting. It was an opinion piece. It was not a research article. There wasn't a single number in the entire article. It simply made qualitative statements, and that is not useful. We need numbers here. And moreover, it did not address the core issue with masks, which is masks protect other people. You know, the measurements they were talking about is that if you go into a patient's room, the patient's sick, you're wearing a mask, it has to be a heck of a good, basically a hazmat suit to guarantee that you're not going to get infected. That is not the situation. If you're in a crowd, if you're in a choir, and you are talking loud, if you are singing, you are a threat to other people, and that threat is made much better if you're wearing a mask. And so it's really important to get the correct information. I'm sorry about that. I'm getting off the subject of this hearing here. When you talk about racial disparities, one thing that concerns me a lot is that there is some indication that there may be a genetic component to this, that there are apparently differences in the ACE2 receptor, the ACE2 receptor that is the entryway, the doorway through which the virus enters human cells. If that is true, then the policy difference is there's a difference in the policy response. For example, we could end up in a situation where we have a vaccine that works better, or a treatment, an antibody treatment that works better in one racial group than another. And I was wondering how we should stay on top of this. I mean, this is a very tough thing to even study because of the huge racial disparities in the provisioning of healthcare and the initial health conditions. And I was wondering if any of the MDs here have, an opinion on what's the state of understanding of whether or not there may be a genetic component to this.
I think that it's too premature to make any assumption on that level. What we do know is that there's no biological basis for race. We know that people of different races actually have almost 99.999% genetic similarity. And so I think even bringing up such a topic perpetuating race-based medicine is potentially very dangerous. But as you alluded to, there are factors such as social and economic policies that have left Black communities and other communities of color more vulnerable and predisposed to this virus. And I
Yeah,
think,
but for example, our office has worked for years trying to get sickle cell treatments based on advanced genetic engineering. You know, that is a very race-linked, it's a single base swap,
it's
and
not
it's racially linked. Yeah.
it's not race, it's a geographical ancestry, which is very different from race. Race is a social construct, and we need to make sure that we differentiate those two. Thank you.
Okay, yeah, no, it's the genetically, okay, you know, statistically, there's, if it's South Asians, I believe it's South and East Asians and African Americans that are the predominant, you know, bearers of this gene. But, you know, if there is if part of this ends up having a genetic basis, I think, you know, we have to make sure that we put effort into understanding whether or not we want to, you know, respond to that, because part of the, you know, it can't be used as an excuse to maintain the disparities in provisioning of healthcare. You know, that's not the argument I was making. The question is whether we have to keep our eye on whether the treatments, you know, may work equally well, depending on things like the details of the ACE2 receptor, which, you know, can be important.
No, I agree with you, but I do think that we need to focus on those social determinants of health, which is what we know are the greatest predictive factors in health outcomes.
Mr. Foster, if I could pipe in here, you're right that there are genetic variations in both the ACE2 enzyme and the interaction between various strains of the novel coronavirus and the ACE2 receptor. So it will be interesting. We're fortunate to live in a golden age of genetics where a lot of this biology can be understood. So I'm optimistic that as we continue to sequence different strains of the SARS-CoV-2 virus and sequence different variations and alleles in the ACE2 enzyme, that we'll be able to come up with tailored therapeutic approaches where needed. But people are aware of that in the research community.
Yeah, but I think it's important that we do a good job of that research. I know that Representative Xochitl Torres Small brought up in the Armed Services Committee the possible use of the armed services data, because that's a population where you control for health and age and so on, and housing conditions. And so you could get use that data to get a real idea of whether there's a genetic component to this. Anyway, I've used up my time, and thank you, Mr. Chairman.
Thank you very much, Mr. Foster. The chair now recognizes Mr. Orlowski.
Thank you, Mr. Chairman. Thanks to our witnesses as well. I want to begin by saying how much my heart aches for the family of George Floyd and for our country right now. There is no place in our society for police brutality, nor is there for the violence and destruction that we've seen in some cities. But even as Americans are exercising their right to protest peacefully, we see countless others being denied their right to gather at a church or synagogue to pray for peace and justice and understanding. I think this is inexcusable at a time when our nation needs prayers for unity and healing. I call on every mayor and governor right now who are still barring the faithful from gathering to reverse course immediately and open up our churches. That's what this nation needs. Every single state needs to have access to their churches. The coronavirus pandemic has affected the whole world, and there's no question its impact has been disproportionate in some populations. For instance, Mr. Roy, you released research last week, and you just spoke about this, that showed nursing home residents make up 0.6% of the U.S. population, but account for an incredible 42% of all coronavirus deaths. Those with underlying conditions such as diabetes, hypertension, obesity, and asthma are also at higher risk for complications or even death from coronavirus. And we know that African Americans are more likely to have many of these conditions. So on this point in particular, there's no simple solutions or instant fixes, but we have to start somewhere, such as exploring ways to improve social determinants of health, the conditions in which someone's social and economic environment shapes their health. I'm a proud co-sponsor of the bipartisan Social Determinants Accelerator Act, which would help states and communities better leverage existing programs and authorities to improve the health and well-being of Medicaid participants. It would also provide planning grants and technical assistance to help state, local, and tribal governments take innovative, evidence-based approaches to coordinate services and improve outcomes. Economic opportunity plays a major role, so I think opportunity zones that were created under the Tax Cuts and Jobs Act can help incentivize public-private investments in distressed communities. But most immediately, we need to continue to reopen, and defeat coronavirus. Safely reopening business doesn't just put money in people's pockets, it boosts their wealth and their well-being. Joblessness is known to have negative effects on mental health. And indeed, many health experts have predicted that prolonging these lockdowns could result in a wide range of problems, such as increased suicide, substance abuse, mental health. Mr. Roy, do you agree that the financial effects coupled with isolation due to these lockdowns have affected physical and mental health of minority communities?
Yes, and Ms. Walorski, if I could emphasize one particular point, which is social determinants of health. We're talking about that a lot today. The most important social determinant of health in terms of correlation with health outcomes, other than income, is educational attainment. And what have we done? We've shut down the schools, even though children are at literally a 1 in a million rate of death from COVID-19. Now, we obviously have to protect their parents and their grandparents and elderly teachers, and we have to be careful about how we reopen schools and strategic. But it can be done. We're doing it in Florida. We're doing it in Texas. It's working. We're doing it in Europe. So reopening schools is absolutely essential. And the longer schools are closed, the worse racial disparities will become in all sorts of dimensions.
Yeah, could you just elaborate on that a little bit, Dr. I totally agree. Is there anything else that you see in this wide spectrum of reinvigorating economies other than schools? What else can you see that will just reinvigorate these communities?
Well, the two things I'll mention in my written statement. I mentioned schools, and the other one I'll mention is hourly workers, right? People who are on hourly wage earners, they're disproportionately low income, disproportionately minority. Their hours, their jobs have been cut by 50 to 70%. It's far worse in lockdown states and localities, and I cite some of that research in my written statement.
Thank you very much. And Mr. Chairman, I yield back. Thank you.
Thank you very much. The chair now recognizes Congressman Raskin.
Thank you, Mr. Chairman. Are you hearing me okay?
Yes, I do.
Okay. Mr. Chairman, the last thing we want to do on this committee is to spread misinformation. So I would recommend that everybody go to the Centers for Disease Control website about the remarkable number of infectious transmissions that have taken place at religious assemblies. At one rural Arkansas church, one person infected 92 attendees. Chief Justice Roberts just handed down a decision saying that there was no discrimination going on against the religious. Obviously, large group gatherings are just dangerous under the COVID-19 crisis. The second thing I want to say is that the public health and the economic consequences of the COVID-19 pandemic and President Trump's lethal mismanagement of the response to it have been devastating for our people. I don't think we've mentioned that we are now over 107,000 casualties, people who have died in the crisis, 2 million people nearly sickened by it, and we have 40 million people who've been thrown out of work. So the public health and the economic consequences together have been devastating ever since this began just 4 months ago. Democratic and Republican governors alike issued public health orders for people to stay at home because we don't have a treatment and we don't have a cure and we don't have a vaccine. So my governor, Republican Governor Larry Hogan in Maryland, issued a stay-at-home order. I'd like to ask Dr. Nguyen, would we have a higher death count today had we not acted as we did, number one? And number two is, doesn't a successful and durable economic reopening require continued aggressive public health action, such as stepped up testing, contact tracing, and quarantine for sick people?
Thank you very much for the question, Congressman Raskin. So first, absolutely, if we had not imposed these stay-at-home orders, we would have far more infections and deaths. This is borne out in research. There was a Columbia University study that found that if we had shut down and imposed shelter in place even 1 week earlier, we would have saved 36,000 people here in the US. Another study published in Health Affairs found that if we did not put into place the shelter in place orders, then we would have 10 times the number of infections. And again, given the disproportionate impact on minorities and people of color, that's 10 times the number of minorities that we would also see. And I just wanted to address your second point too. The White House issued their own guidelines about reopening. And specifically, the guidelines said that we have to have a 14-day consistent decline in the number of cases, and also that there must be testing, contact tracing, isolation capabilities available. No public health expert that I know would argue that we need to close down permanently or that we need to close down until we get a vaccine. We're saying that we need to see that there's a decline in the cases and also that these capabilities are there. Unfortunately, the federal government has not had a national strategy for testing, for contact tracing, for developing the public health infrastructure. So that time that the shelter in place orders was supposed to buy us, unfortunately, was squandered. And we are reopening before we're ready. And I just want to add too that it's not just the elderly in nursing homes who get ill. It's also young people who die. There are children. Now we know about this multi-system inflammatory syndrome that causes multi-organ failure that's landed children in ICUs. Kids have died from this. Young, otherwise healthy people in their 30s and 40s have gotten strokes. And so we need to take that into consideration.
Thank you, Dr. Wen. We need real data to address the effects of racial inequality on the spread of the pandemic, which is why we passed a law last month requiring the administration to provide specific demographic information on the rates of case spread, hospitalization, and death as a result of COVID-19. The administration filed its first report, if you can call it that, to Congress on May the 20th, and it really is a joke and an affront to everything we're trying to do. The report, if you can call it that, is 3.5 pages. Page 1's the cover page. Page 2 is a copy of the law that we passed. Page 3 is a collection of links to the CDC website. Dr. Blackstock, why is it crucial for Congress and for the people to get racial and ethnic data on the coronavirus epidemic? And what should the administration be doing to improve its dismal performance in collecting and reporting this data?
Thank you for that question. I will say that the federal administration's response to the data collection has been quite anemic. Even the CDC, the data that we have from the CDC is incredibly incomplete, and we need the full data in order to get a full picture of the degree of devastation to these communities of color. Without the data, we don't know how much resources these communities need. And so that's why we really need every state and locality to disclose not only hospitalizations and deaths, but we also need to know testing. We've seen that Black Americans are less likely to be tested. And then when they go to the hospital, they're more likely to be admitted. So that points to significant structural factors that we need to understand better. And by having the full data, that will allow us to equitably allocate resources to the communities that need it most.
Thank you very much. I yield back, Mr. Chairman.
Thank you very much. The chair now recognizes Congressman Leane.
Thank you, Chairman Clyburn and Ranking Member Scalise, and thanks to our witnesses. This is an important topic, especially in light of the critical national conversation we're having as we continue to mourn and seek justice for George Floyd. Having been an emergency room physician 20 plus years, working in inner city ERs, rural ERs, suburban ERs, I know that when a patient comes into the ER, it doesn't matter what race they are, we treat them all the same. And having been a special operations flight surgeon in the Army, I've seen firsthand that our soldiers, whatever race they may be, that blood on the floor of the Black Hawk helicopter is all red when you wash it out. I want to ask all Americans to look at the National Guardsmen in their communities right now. In their ranks are Caucasians, African Americans, Latino Americans, Asian Americans, and together, united, they are protecting Americans. That unity can be an example to us all. The data on COVID-19 has shown clear disparities, and it's important we get to the bottom of it. But we need to be careful when analyzing the data, as numbers can be misinterpreted due to dependent variables that confound the data. For instance, in Louisiana, 54% of COVID-19 deaths were African Americans, even though white people make up 63% of the state. However, when you look more closely, the vast majority of the deaths are concentrated in urbanized areas such as Orleans Parish, which is over 60% African American and which has the most deaths. However, other majority African American parishes in rural areas in Louisiana, such as East Carroll Parish and Madison Parish, combined saw only 2 deaths. We know coronavirus is spread in various ways through droplets, aerosols. The key factor every transmission has in common: proximity. The coronavirus appears to be hitting those in dense urban areas the hardest, and minorities are more likely to live in dense urban areas than white Americans. It's no surprise that congested apartment buildings can increase the risk of COVID-19. And not only do we have denser living conditions in urban areas, consider the other differences, say, between New York City and Lawrenceburg, Tennessee. The packed sidewalks, the prevalence of public transportation, the crowded elevators, the tight workspaces. If we draw conclusions that this is all due to some race bias in healthcare, we may miss the need to analyze how we sterilize public buses or subways, which, since urbanization is a clear dependent variable, we need to do that. Another dependent variable is the disparity in comorbidities. High blood pressure is more prevalent among African Americans than white Americans, and as Chairwoman Woters has said, we have been studying this disparity for 50 plus years. One study found that, quote, the population attributable risk for hypertension and 30-year mortality among white men was 23.8% compared with 45.2% among black men, and 18.3% for white women compared to 39.5% for black women, unquote. There are studies that suggest this could be to the way African Americans process salt in the kidneys, but honestly, no one, after all these years of studying it, has 100% found the medical answer to this disparity. There seems to be lots of dependent variables there as well. A study published in the Journal of the American Medical Association noted that 57% of those with severe COVID had hypertension. African Americans are also at a higher rate for diabetes. 11.7% of non-Hispanic Black people have diabetes versus 7.5% of non-Hispanic whites. A peer-reviewed paper in the Journal of Diabetes Science noted that the risk of death from COVID is 4 times greater with those with diabetes. It's clear that a number of different factors contribute to greater rates of infection, higher numbers of severe cases, and more deaths from COVID. The same factors are true not just for Black people in the US, but across the world. In Brazil, hardest hit state of Sao Paulo, Black Brazilians are 62% more likely to die from the virus than white Brazilians. And according to the UK's Office of National Statistics, Black people in Britain are 4 times more likely to die from COVID than white people. That's higher than in America. And the UK has universal health care. Let me say that again. And here I disagree with Chairwoman Woters. The UK has universal health care, i.e. government care for all, and the disparity between Blacks and whites there is higher than the United States. Unfortunately, due to numerous factors, COVID-19 is hitting disproportionately our Black brothers and sisters across the globe. We must tackle this issue using a science-based approach that will truly help them. Only when we understand all of those interlocking dependent variables can we really get to the bottom of it. Hopefully we will with hypertension. Hopefully we will with COVID-19. We've got to continue studying it. But we got to make sure we look at the data fairly. Thank you, Mr. Chairman. I yield.
Thank you, Mr. Congressman Green. Now we recognize Congressman Kim.
Thank you so much, Chairman. I would like to address questions to Dr. Wen and Ms. Sharp. I wanted to start with you, Dr. Wen, to pull on a thread that's been talked about through the course of this briefing. It's about reopening. And I'll start by saying I want to get things reopened as quickly as we can in a responsible and safe way. My home state of New Jersey has been hit particularly hard by the virus. And I know that a lot of small businesses are struggling, a lot of other folks are struggling. When we're thinking about how we reopen, there's been some discussion already during this briefing about this. Something that comes to mind is what you said about the White House Coronavirus Task Force. And it reminded me, I actually went and just looked at this. The criteria that they say is data-driven conditions each region or state should satisfy before proceeding to a phased opening. I wanted to ask you if all states in our country have met the conditions that the White House and the Trump administration has laid out.
No, they have not. And in fact, many public health experts, including myself, have argued that no state has met these criteria. Many states have not met the criteria for consistent decline in the number of cases, but no state has met the capabilities, the widespread testing, for example, that we need. And that's because we need national leadership, a national strategy to get there.
I appreciate that. I just wanted to make it clear just where things stand when it comes to the Trump administration's guidelines on reopening. I wanted to turn a question back to you, Dr. Wen, about the Asian American Pacific Islander population. As I've gotten a chance to speak with AAPI communities across the country, a couple of things have come out that we haven't talked about necessarily in this discussion so far. First and foremost, with AAPI, it's not just about the effects on patients and those that are getting infected. There is also a high number of AAPI that are essential workers, a high number of AAPI that are physicians and nurses. I think the last estimate I saw was that over 2 million AAPI are considered essential workers right now. Over 20% of physicians in our country are considered AAPI. So that is a huge aspect of this as well, as just the impacts on the health side when it comes to the AAPI community. In addition to this, as mentioned before by a colleague of mine, Carolyn Maloney, about communication, the AAPI community as well has had a tremendous amount of difficulty when it comes to getting this information about the coronavirus due to language barriers. I've heard a lot of people talk about, especially in North Jersey, where incidents have been rampant, about the Korean American community, Asian American community, not knowing where to go for testing. And as I looked into try to understand whether or not there's a disparity by race and ethnicity when it comes to testing, I've learned that only 4 states in our country actually track data for those that are getting tested, breaking that down by race and ethnicity, which makes it very hard for us to know whether the data about deaths and those percentages falling ill is actually manifesting in an accurate count and a representational count. So I wanted to just get your thoughts on some of those issues affecting not only AAPI communities, but all communities when we don't have that data.
That's right. So we need far better data for infections, hospitalizations, deaths, and critically of testing so that we know whether we are targeting our resources to communities that actually need it. We also need better data in general. We actually have very little data on AAPIs overall. The data that we have, for example, show that there are disproportionate numbers. In South Dakota, the rate of COVID-19, for example, among Asian Americans is 6 times what would be predicted based on demographic data alone. So we need that data specifically. Also, you mentioned about outreach. We need to have people who speak the language, who are culturally competent, who are the most credible messengers. And I think a point on the data too, the more testing we have, the better surveillance we can have too. Often we find that when there is one case, there are dozens or hundreds of others. And actually it's that testing, that early surveillance that will offer the roadmap for reopening. This is what other countries have done to successfully reopen. This is what we need too, and in particular targeting to minority communities, including the AAPI community.
No, that's right. And when we're talking about contact tracing, if you're not able to communicate in that language, it makes it all the more difficult. Ms. Sharp, I just want a final question to you. I was really moved by your statement, and you talked about the challenges that we're facing the Indian Health Service writ large on funding, even before this pandemic. I want you to paint for me a picture of how this lack of funding affected the health of American Indian people even before this pandemic struck, and how that set the tone and the foundation for which the response occurred.
Yes, thank you. I really appreciate the follow-up to that question. Long before the pandemic hit this country, we are already in a crisis. We suffer in some areas upwards of 80% unemployment. We suffer large-scale economic impacts. So some of the questions that were surrounded around reopening, we already faced those prior to the pandemic. And so what we've found is that not only do we have an inability to protect ourselves during this pandemic, but we have notable every sector of the funding that we receive from the federal government is chronically underfunded, whether that's law enforcement, healthcare, education. Every part of our public life is deeply impacted. And not only that, but the ability for us to raise our own revenues through taxation has been severely limited. And even with economic relief through the CARES Act, we are disallowed from using that relief to support our economies that we've built. And so in the absence of the federal government funding the trust responsibility, we've tried to raise taxes. That's been limited. And when that's failed, we've tried to raise commercial profits through enterprises, through tourism, through resorts, and that is severely limited. So not only do we not have a trustee that's funding us, we have an ability to raise our own revenues. And when we do, it's economically hijacked from state and local governments, leaving us without a defense. And so when this pandemic hit, we too saw that there was no national strategy. We looked to the World Health Organization for the 4 pillars, and we began immediate rapid testing, trying to see how we can get testing to our communities. And we saw that the FDA was approving emergency use authorizations for some companies. And we found that if we were to be able to have those companies test within our communities under tribal law for tribal citizens within our areas, that would be a start. But all of those things have left us in a place where, when I saw the images coming out of Italy and Spain, it was clear to me that if we don't protect ourselves, we're going to be part of the calculus just left to die.
Thank you, Ms. Sharp.
Thank you.
Back to you, Chairman.
Thank you very much, Ms. Sharp, and thank you, Mr. Kim. Before closing, let me yield to the ranking member for whatever closing comments you may want to make.
Thanks, Mr. Chairman. And again, thanks all of our witnesses for this hearing and the members who are participating. I think a lot of important things came out clearly. We've seen data that shows where the disparities are and how COVID-19 is affecting our country. It's not affecting the country equally. It doesn't affect age groups the same. It surely doesn't affect people of different backgrounds. Minorities are the most impacted. Seniors in nursing homes are the most impacted. I think Dr. Green's points I thought were so poignantly made that when you look at different parishes in a state like my home state in Louisiana, the African-American community in a city like New Orleans is very adversely impacted differently than an African-American community in a rural parish in Louisiana like West Carroll. So I appreciate you making those points. Of course, Jackie Walorski talking about the need to reopening our churches. We need to be praying right now. We need to be coming together as communities in those places that we go to gather. We know how we can do it safely. Dr. Roy pointed out those protocols. States have already shown us how to do it the right way. We ought to be following those states, just like we saw with nursing homes. Some states are doing it right. Some states are doing it wrong. If a state like Michigan wants to keep doing it the wrong way, we ought to be all pushing to stop them from doing it. It's killing people. And so as we share this information, I think it can be helpful if we use the data we're getting and the knowledge we're gaining to share it with others who need it the most, who can help us save lives and then get our economy back opening, which also saves lives, as we see in the testimony. So I appreciate, Mr. Chairman, your focus. And again, I know as we all extend our prayers to George Floyd and his family, let's all keep working to make this better. Thank you, Mr. Chairman. I yield back.
Thank you very much. In closing, I want to thank all of our panelists for their remarks here today. We are grateful for your work, your insights, and your leadership during this time of great crisis in our nation. I also want to thank you, Mr. Scalise, and all of my colleagues on this committee for their participation and contributions today. It is clear from today's panel that the coronavirus pandemic has imposed an unequal burden on communities of color. But it's also clear that this burden has been building for centuries as Black and Brown Americans have faced numerous barriers to high quality health care. I want to thank Dr. Blackstock. She mentioned the Tuskegee experiment. I always say that we ought to be informed by our history. She also mentioned Dr. Henrietta, or Miss Henrietta Lacks. She should be a doctor for all that she's contributed to healthcare. And I would ask my colleagues here, if you do not know about Henrietta Lacks, please Google her. I think you'll see why her name was mentioned here today. We need the federal government to respond to this current crisis by getting minority communities the testing, protective equipment, and treatment they need. But we also need to sustain investment and structural change to ensure racial equity in the future, including universal access to high-quality health care. I often quote Dr. Martin Luther King Jr., who back in 1966, speaking at a medical conference, said this: of all the forms of inequality, injustice in health is the most shocking and the most inhuman. He didn't say inhumane, he said inhuman, because it often results in physical death. End of quote. We have seen too much unequal and unjust physical death from multiple shocking and inhuman causes. And we are now seeing direct action and creative nonviolence. The conscience of the nation is being raised, and it is my hope that racial inequities in health and other areas will be addressed. Thanks once again to all of you, and this briefing is adjourned.